are those people that traditionally have rendered prescription orders to be then fulfilled by your pharmacy, if you happen to be in a community pharmacy, and you basically follow their orders and then dispense the drug accordingly to the patient. These folks have the legal authority to get delegated prescribing authority from these people. All right, so these people have inherent prescribing authority. These people, the delegated people listed in this, and there's others included that can be included depending on your respective state. And again, each state has its own set of rules and regulations on what types of healthcare practitioners are allowed to receive delegated authority to initiate or prescribe drug therapy. And in California, it happens to include nurse practitioners, physician assistants. In California, there's this new thing, relatively new thing called a so-called advanced practice pharmacist. And we'll be talking a little bit about that. And others also are allowed to get a delegated authority. So if you're a pharmacist, and again, this really turns wholly on the rules and regulations that govern this issue in your particular state, you as a quote unquote normal pharmacist or a regular pharmacist will probably have some authority to be able to receive delegated legal authority from a prescriber to be able to render certain clinical practices. This is one of a couple of the California regulations on point that speak to what a advanced practice pharmacist in California is allowed to do. And they can do 1 through 5. They can actually perform patient assessments. Now, mind you, patient assessment is merely that, just assessing the patient. It does not mean, however, and the state legislature was very careful not to do this, it does not mean that the pharmacist has any legal authority whatsoever to make an initial clinical diagnosis. So all things, if you consider the basket of things that a typical physician does, for example, in his or her place of practice, there's a bunch of things that are performed on the patient, to the patient as part of their overall health care. The one thing that, at least in California, pharmacists are not allowed to touch still yet is making the initial clinical diagnosis. So pharmacists, one, they are allowed to assess patients. Number 2, they're allowed to order and interpret drug therapy-related testing. 3, they can refer patients to they can do, clinical triaging. Number 4, they can participate in the evaluation and management of disease conditions in collaboration. And number 4 and 5 are sort of intimately tied. And 5 says specifically, very importantly, that pharmacists are allowed to initiate, adjust, or discontinue drug therapy in a manner specified in other code sections. Number 5 was just for those of you that take interest in legislative affairs, number 5, the wording of number 5 was very fraught with landmines as the initial drafts did not say initiate, adjust, or discontinue. Number 5 just said prescribe. And so that was a big no-no in the state legislature because of the understandable turf battle that may have been created by virtue of using the word prescribe in subsection number 5. So in the world of pharmacy, at least in California, we tread very carefully, very lightly around the word prescribing, and that we don't use it, at least insofar as what pharmacists can do. Rather, pharmacists can initiate drug therapy, they can change it, and they can stop it. And that's really the extent of at least for the purposes of us and what we want to do here, that's a very important thing that, at least in California, the law allows pharmacists to do. Furthermore, the code sections, talk about the more details on exactly how to initiate or adjust drug regimens. It talks about a specific protocol that says, the pharmacists are allowed to initiate a drug therapy, obviously pursuant to a written prescription order or an authorization made by the individual's treating prescriber, or rather, and in accordance with the protocols of the physician. So this is the first section that kind of opens the door for the possibility of something unique, a little bit novel as compared to traditional physician and pharmacist relationships. The pharmacist can adjust the drug regimen, but adjusting the drug regimen for the purpose of this section does not include substituting, selecting a different drug except as authorized by protocol, and the pharmacist shall provide a written notification to the prescriber. So there is a great opportunity for pharmacists to initiate, amend, or discontinue drug therapy, but so long as there is this protocol agreement before the initiating, amending, and discontinuing drug therapy happens. And then after the initiating, amending, and discontinuing drug therapy happens, there has to be a subsequent follow-up, at least a written notification from the pharmacist to the prescriber about what exactly happened. So with regards to the specific contract now, all right, there needs to be a contract, and you should very much look at the agreement between the prescriber and the pharmacist as a service contract, because at its core, that's essentially what it is people, the prescribers that have legal authority to start and stop and change drug therapies, allow through this service contract the recipient pharmacist to do certain things that are allowed to be done by the prescriber. Now, this contract, there's a couple of stopgaps and some boundaries and borders you cannot exceed. And first and foremost, whatever a delegated authority is bestowed on the pharmacist by the prescriber needs to first have that inherent authority. So example, number one says that, the general consideration is that the delegated authority from the prescriber to the pharmacist cannot exceed the prescriber's own inherent authority. For example, you would never, by law, a veterinarian trying to enter into a CPA with a pharmacist to initiate drug therapy for lower back pain just isn't going to happen, because no veterinarian has that authority inherently. Kind of an obvious example there. Number two, that contract should strictly define the parameters of the delegated authority, listing out the specific functions and duties bestowed to a pharmacist. We're going to go to, in a couple of slides here, an example of a typical provision that would see that I've written up by way of these CPA contracts between prescribers and pharmacists that have worked pretty well. Generally speaking, the more detailed the contract lists and details the specific things that you as the receiving pharmacist can do, the better off and more robust and enforceable the contract is. You never want to have a contract so open-ended that the contract says something like, me as the MD here, delegate whatever and everything that I can do under the sun to the pharmacist. That is not a meaningful contract, and quite frankly, that could potentially get you into some problems should a patient be harmed, for example, down the road. Number three, the pharmacist, and this goes to what I said a little earlier, a pharmacist cannot make the initial diagnosis. And I know that number three is a little bit fuzzy and gray, because I think a lot of pharmacists need to sometimes stop themselves when they're dealing with a patient that's been sort of handed off to them from the prescriber, where, for example, the prescriber will hand off the patient to the prescriber's delegated CPA pharmacist, and the pharmacist will start taking care of them and managing their care, where the initial diagnosis, for example, what may have been, hypertension, but during the course of the, just the natural progression of the professional relationship between the pharmacist and the patient, the pharmacist will pick up on other symptoms such as diabetes, other comorbidities that are very frequently associated with hypertension, and the pharmacist needs to stop themselves and not start treating the other diagnoses that were not initially recognized by the delegating prescriber. So number three sometimes gets pharmacists into a little bit of trouble. And just to let you know, to date, I have not yet had any case that I've managed or heard or read of any case where a pharmacist within these types of protocol agreements has ever gotten in trouble with the government for anything. Quite frankly, probably because they're too new. Quite frankly, because not many pharmacists do this, probably because they don't know that they can do this. But I'll tell you that this next generation, this wave of this influx of, well, in California now we have 13 schools of pharmacy, so I'm sure that's probably the reason why, where pharmacists are looking to do more different and novel things as compared to times past. This whole notion of a CPA agreement is becoming more and more enticing and alluring to these pharmacists that are, they're charging straight out of school, and they want to make a gangbuster initial positive influence in healthcare. They're not nearly as afraid as compared to their predecessor colleagues to do these relatively new and novel things. With regards to number four, to the extent controlled substances are involved, and it's very foreseeable that a delegating prescriber who perhaps maybe a pediatrician may have diagnosed hypertension, hyperactive deficiency disorder, or some variation thereof, and a controlled substance is involved. So if you're that pharmacist in that type of a CPA relationship with the prescriber, then make sure they have the underlying foundational licenses and legal authorities to do the things required, in this case, be able to initiate, amend, and discontinue the drug therapies for controlled substances. And most of you probably already know, but as a pharmacist, you are allowed to hold a DEA registration as a, quote, mid-level practitioner. So for those of you that have not yet, that are seriously thinking about going into this thing called a collaborative practice agreement with your local prescriber, then one of the things that you might want to do on your due diligence checkoff list is to go on the DEA registration website, and it's the very same DEA website that pharmacists go to register themselves as dispensing pharmacies. Get yourself a mid-level practitioner DEA registration so that you can then participate fully to the extent your delegated prescriber wants to have you initiate, amend, and discontinue controlled substance drug therapies. So I'd like to share a couple of sample provisions that I found quite helpful that I seem to commonly refer to again and again within the various types of collaborative practice agreements that I've helped draft for pharmacists. First and foremost, it helps, at least in California, that pharmacists are recognized as healthcare providers. And I only say this because this opens the door for billing and compensation for your services. And again, I know for a fact that not all states in this country recognize pharmacists as healthcare providers. Certainly, the federal government does not as of yet. Pharmacists are not included within the coveted list of coveted list of providers within the Social Security Act. But on a federal level, we know that we're all working towards that end. There are many vested interested parties that are trying to get pharmacists onto that list. But at least on a state basis, this helps get reimbursed and compensated for your services. So let's see. So this is one specific provision that I have pretty much included in all of my contracts between prescribers and pharmacists because it references the specific code section that allows for the existence of this contract in the first place. So the provision reads, the prescriber authorizes to pharmacists after I've, in a section above this portion, I've identified who the prescriber is, I've identified who the pharmacist is. The prescriber authorizes to pharmacists, and pharmacist wishes to receive, excuse the typo, delegated authority from prescriber to manage prescriber's patients pursuant to the parameters and specific delegated authorities defined in this agreement. So heads up, there's going to be a portion of this agreement in which we're going to define all the things that the prescriber is delegating to the pharmacist. This authority complies with California BMP section 405.2.6 to be effectuated by pharmacists either inside or outside of a licensed pharmacy. So I think this brings up a good point, is that just because, most of the dispensing happens within the four walls of a licensed pharmacies, by no means, at least in California, are you necessarily as a pharmacist restricted to only doing these delegated authorities within the four walls of a pharmacy. So, just be aware that, for those of you who have a clinical interest in doing other things besides dispensing, or you don't want to work in an institutional or hospital setting, but you want to render your clinical good works in an outpatient setting, there's real possibilities out there to make a meaningful impact. This is a specific list that also is that I usually include in my contracts between prescribers and pharmacists, is that I basically mimic the law. Basically because it's a safe place to be. So I try not to get too cute or too creative with regards to what the law allows, and I basically recite all the things that are allowed to be done by a pharmacist pursuant to a CPA as the law says. Okay, but in addition to that, this is the portion where I start to talk about the specific detailed things that pharmacists are allowed to do. So this is a very important provision, and this is the portion, quite frankly, where I spend most of the time with my pharmacist clients because they're sometimes not quite sure. They know that they want to do a lot of clinical good works. They know that, especially if the delegating prescriber happens to be a general practitioner or internal medicine, there's a whole wide array of types of conditions and types of patients that can be handled and managed by the pharmacist. So recognizing that and this type of a provision would be suited to, it's totally customizable depending on really the limitations of how comfortable your delegating prescriber feels about your clinical competence as a pharmacist. And that's really all what it comes down to. Because my general experience has been that prescribers are more than willing, and they love this idea of having pharmacists take care of the drug therapy portion of their patients. And they love nothing more than just basically pass off their patients to the pharmacist to manage, at least for, certainly for chronic conditions and conditions that require at least some modicum of monitoring their activity and their and the clinical presentations over a long course of time. So in this specific provision, I write that the prescriber shall delegate to pharmacist authority to manage and or treat the prescriber's patients in accordance with the section. In managing and or treating the prescriber's patients, the pharmacist may initiate, modify, discontinue, or discontinue prescription medication therapies for the following predetermined conditions and diagnoses. And I specifically call out certain ICD-10 codes. And I have had protocol agreements where this list has been just this one, the ADHD. I've had other, and again, this is purely a function of the degree of professional trust that the prescriber has in you, the clinical pharmacist, manage these types of patients and conditions. I think the longest list that I've had was something like 25 or so ICD-10 codes, for which there was a very strong, obviously, professional trust that the prescriber had in the clinical pharmacist, and to this day they're working quite nicely. This is just one of many ways that you can address this specific detailed list of the types of conditions, the types of patients that is going to be managed. In the world of compounding, I could very easily see, BHRT, as controversial that has become now. There's still a lot of compounding pharmacies and pharmacists that engage in bioidentical hormone replacement. And so this would be a great way to drill down to what exactly, are you going to be doing for the prescriber, for their patients that you handle. Oh, and a thought came to mind before I forget, that you have to be careful in these. I've had a number of pharmacists come to me and saying, look, I don't want to kind of I don't want to, kind of tie myself down to one prescriber. I want to be able to, deal with a bunch of prescribers at the same time. Is there anything wrong with me entering into a protocol agreement contract with multiple prescribers within my community? The answer is absolutely not. I have not had a single situation where prescribers have said, you're mine and you're only mine, and I'm not going to share you with anybody else. Prescribers are quite generous. Now, the limiting factor there would be you as a pharmacist, have to deal with the fact that there are only 24 hours in a day, and you do have to sleep and eat and take care of yourself. So within the typical, 8 to 12 hour workday, as is the case for most pharmacists under these CPA agreements, you have to sort of kind of, pick your battles here, because while on the one hand, no collaborative practice agreement that I've ever drafted has an exclusivity provision that says that the pharmacist can only work with the patients of this prescriber. A lot of pharmacists usually don't want to work with more than one, maybe two prescribers in the area, because they very quickly find out, if they're any good, that is, as a clinical pharmacist, that these prescribers are going to just shove boatloads of patients to the pharmacist's way, to have the pharmacist take care of and manage their patients. And so I think you'll find that, for those of you that are really, gung-ho about this idea, I'd say take baby steps and see how it fits. Pick one local prescriber in your area that you have a good, comfortable working relationship with, and see how this works for you before you decide to take on any more. And there is a responsibility on you as a pharmacist. Yes, you probably graduated from a school of pharmacy accredited by ACPE and got a pharmacy doctorate degree, but that does not necessarily mean that you're going to be the expert on all types of drug therapies for all patients. And so from that standpoint, I would say from a more practical standpoint, and to make sure that you don't commit malpractice, and that you do not breach the trust that is bestowed on you by your delegate and prescriber, pick a condition or two, or and be the expert on that. And to the extent you feel more comfortable broadening your scope of clinical offerings, gradually take it on a step-by-step basis that way. I've had a couple of pharmacists who want to do everything all at the same time right now, only to find that, okay, well, maybe a moderate amount of information for a bunch of things, but you're not really an expert in any one. So I found that to be the case in many situations where they have to then kind of scale back, and then they look a little bit foolish, and they get a little bit embarrassed in the eyes of the prescriber, who the pharmacist may have puffed themselves up a little bit too large, only to be kind of forced to kind of backpedal a little bit later on. So don't find yourself and try to avoid that situation if you can. With regards to, I get a lot of questions about what about liability insurance? Are there any specific, caveats or considerations for that? The answer is, well, not really. So to be clear, when it comes to professional liability insurance, okay, professional liability insurance is, oh, I just realized my video is not on. Oh, now it's on. Oh, okay, here. Hello, everybody. I just realized I was not on until just now. All right, so with regards to liability insurance, I get a lot of pharmacists are a little bit confused about what's required, if at all, in terms of extra liability insurance. Most pharmacists that practice in an outpatient setting usually have about $1 million comprehensive liability policy, and quite frankly, it's quite cheap. And the reason why liability insurance for pharmacists is quite cheap is because historically, actuarially, pharmacists pose a very low risk of getting in trouble with anybody. And in terms of, within the context of negligence and malpractice, historically speaking, pharmacists have not cost insurances very much. And that's why pharmacists currently enjoy a fairly cheap liability insurance, certainly as compared to their healthcare professional colleagues within medicine and nurses. Similarly, with regards to this added thing that you're trying to do as an outpatient pharmacist to now start engaging in clinical services, the question that comes to mind in most pharmacists is, well, do I need to get some special other liability insurance or what? And so my response to that would be to go back to the insurance carrier that you got your professional liability insurance from as a pharmacist and tell them that you now want to do this new thing, and what can I do to make sure that all these new scopes of activities will be covered as well. Well, your insurance company will probably want to get a copy of the collaborative practice agreement. So all the more reason why you need to sort of codify your interprofessional relationship between you and the prescriber. And then I think you'll be pleasantly surprised that the any extra liability insurance that you would sort of fear in your mind is really not that big of a deal. Only, I think, not that much money, a couple of extra bucks, quite frankly, per month if you really want to break it down. Again, because number one, there isn't that much established history of pharmacists doing this thing. And second is, for those that are doing it, nobody's getting sued for negligence or malpractice. So knock on wood, so far, our pharmacists are doing a pretty good job, at least those that are already out there doing these CPA agreements. So with regards to the insurance, and by the way, I've had some pharmacists try to sort of tack on some extra coverage, kind of riding on the coattails, if you will, of the delegated prescriber. But unfortunately, the delegated prescriber's insurance malpractice coverage refuses to take on any additional liability that may befall as a result of this agreement. So most, I've not had a single prescriber be okay with kind of a piggyback trailer type of a added coverage. Rather, the prescriber has specifically required the pharmacist to get their own additional professional liability insurance, and in fact, have the pharmacist essentially indemnify the prescriber. In other words, if the pharmacist does something within creates harm to a patient or causes injury to a patient as a result of this protocol agreement, then by contract, the pharmacist agrees to basically step up and defend the delegated prescriber to the extent the injured party decides to sue not just the pharmacist, but also the delegated prescriber. So, but again, I've not known of any specific cases on point yet. Again, knock on wood. And I would very much expect this to sort of be the case so far, case going forward. All right, let's answer the questions. True, false. Community pharmacists may never render clinical services in outpatients unless they have completed a PGY1. No, absolutely not true. It is very possible, at least in California, again, check your own state regulations on this issue. There is no requirement to do PGY1 to enter into any collaborative practice agreement. Two, true, false. It's possible for pharmacists to make an initial clinical diagnosis as a provider. False. There is no authority allowed by law. I'm not aware of any state that has this allowance. California certainly does not, but pharmacists may not engage in the initial clinical diagnosis. And lastly, true, false. It is possible for pharmacists to initiate prescription drug therapy as a provider. Yes, it is true. Now, within California, there is a so-called advanced practice pharmacist, and that's a newly created licensure in addition to the regular pharmacist RPH that's typically seen in California. This advanced practice pharmacist allows, for the first time, kind of this blowing open the doors wide open for for pharmacists in an outpatient setting to do the things that, quite frankly, pharmacists have quite for some time already been allowed to do in an inpatient setting. So depending on where your state is at, see if you see what your state regulations and laws say about this this concept of an outpatient community pharmacy rendering clinical works on an outpatient basis in a similar manner that has always historically usually been available for pharmacists in an inpatient setting. And with that, any questions? Anybody want to throw a question out there?
Yes, thank you so much, Tony. Yes, if anybody, they can either raise their hand or, if I made them a presenter, they can unmute and ask questions. Such an interesting topic in a presentation. Nobody's got any questions?
I won't even charge you. I'm an attorney.
There you go. There you go.
Wow, this is the first. I've never had anybody miss out on an opportunity to talk to an attorney for free.
I know. All you have to do is raise your hand and ask. I'd love to know why some people joined, what their objectives were, what their interest was. Does anybody want to jump in? Lou, how about you? I know you love to talk about things. Lou, any thoughts?
Well, while people muster up confidence, I will tell you that there are many types of agreements, and I think it can range from the full 9 yards clinical of renderings to something that's very limited as allowing a pharmacist to initiate like a treatment authorization request or one of these pre-authorizations for PBM purposes. Because I know a lot of pharmacists are getting in trouble with their local PBMs because the PBMs are alleging that the prior authorization needs to be done and initiated by a prescriber. This is one contractual way to work around that, where if the prescriber, instead of initiating instead of being the one to initiate the prior authorization, in the case of a compounded medication, for example, if you want to get prior authorization to get it covered by your PBM, this protocol agreement will give you the contractual authority bestowed on you, the pharmacist, to be the one to initiate that prior authorization request, if in fact it's listed within your protocol agreement. So that's a very creative, novel idea that gives you a really good standing with the PBMs, to the extent PBMs really don't seem to like and care for pharmacists to be the one to initiate the prior auth requests.
Okay, great, thanks. All right. Well, if nobody else has any questions, anything, Tony, that was an excellent presentation. I really appreciate you doing this for us. Is there anything else you want to mention before I release everybody for their breaks?
No, just thank everybody for coming. As the principal attorney for my law firm, the California Pharmacy Lawyers, we're very proud to be a sponsor. And to the extent you have any questions in California, either doing business in California or want to do business in California, feel free to look us up. I think our law firm appears on one of your pages. I'm not exactly where to go there, but look us up and we'll be glad to help.